Madam, we will start. Good morning to you all. Good morning to you all. Welcome to this national webinar on poverty. Please, all of you, please mute your phones, please. Please, I request you, all of you, please mute your phones. Good morning to you all. Chief guest of today's national webinar, Professor K. Samantha Madam. Madam is Rector, Andhra University, Visakhapatnam. Today's resource persons, Dr. P.V. Sudhakar Garu. Sir is Principal, Andhra Medical College, Visakhapatnam. And another resource person, Professor Sangamitra Sheel Acharya. Madam is...
Hello, sir. Your voice is not audible for us.
Okay,
Hello?
okay, madam.
Hello, we are unable to hear your voice, sir.
At present?
Sir, madam, it is audible, man, no?
Hello?
It is audible for us, sir.
Hello?
We can hear you. We can hear you. I am not sure about Rector Madam's office.
Even I can hear you.
వినిపించట్లేదు మేడం అసలు చాలా లో ఉంది
Madam, please press F3. Please press F3 in your computer so that the volume gets increased.
Okay, another resource person with us.
ఇందులో లాగిన్ అవునా మేడం
Sangamitra Sheel Acharya. Madam is Professor of Center of Social Medicine.
అక్కడ ఉన్నారా పక్కన ఏసీ హాల్లో ఉన్నారా చూడు ఈయన సుబ్బారావు గారు
మేడం 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 is it audible?
We are unable to hear your voice, sir.
Vamsi is coming to you, madam.
Not audible. Not audible.
Coming to your chamber.
We can hear you, but I think maybe ma'am's.
నాకు అసలు వినిపించట్లేదు
బ్లూటూత్ కనెక్ట్ చేశారు బ్లూటూత్ కనెక్ట్ చేశారు సార్ ఈజ్ యువర్ వాయిస్ ఆడిబుల్ సార్
Yeah.
Yes.
Okay, madam.
Okay. Now it is audible.
Okay, madam. Thank you. Another research person, Professor Sangamitra Sheel Acharya. Madam is Professor of Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University, New Delhi. Dear participants, colleagues, press and electronic media, I welcome to you all. I am Dr. P. Subbarao, Director, Center for Study of Social Exclusion and Inclusive Policy, Andhra University. Today, I am very happy to inform you that as part of my center's activities, we are organizing this very important and contemporary topic on poverty and malnutrition, for which we have two eminent personalities with us to deliberate all these issues. However, for the formality's sake, I would like to share few lines with you. Friends, poverty is a proximate determinant that mediates through inadequate dietary intake, lack of access to sanitation, hygiene, and poor environment. On the other hand, malnutrition is a complex and multidimensional issue, primarily caused by several factors such as poverty, inadequate food consumption, inequitable food distribution, improper maternal, infant-child feeding and care practices, economic inequality, gender imbalances, poor sanitation and environmental conditions, restricted access to quality health, education, and social care services. It is also important that malnutrition in India persists because of the age-old patterns of social and economic exclusion. Studies shows that despite the declination of inequality across the different socio-economic groups, the level of malnutrition is still higher for the poor and disadvantaged. As Amartya rightly commented that famines are caused not by shortage of food, but inadequate access to food. According to him, for the poor and marginalized, access to food is impeded by social, administrative, and economic barriers. It is estimated that despite India's 50% increase in GDP since 2013, more than one-third of the world's malnourished children live in India. Among these, half of the children under the age of 3 years are underweight. According to the Food and Nutrition Security Analysis India 2000 report, authorized by the Government of India and the United Nations World Food Program, stated that malnutrition among children in India is projected to remain high despite all the progress made in food security. The World Bank also estimated that India is one of the highest ranking countries in the world for the number of children suffering from malnutrition. According to the Register General of India, the mortality rate of the children under the age of 5 years was about 59 out of every 1,000 live births, which is one of the highest rates in the world. Save the Children organization commented that this is mainly due to the lack of proper food among these children. The organization also stated that poor nutrition within the first thousand days of children's life can have many negative causes to them. It can lead to stunted growth, impaired cognitive ability, neglected school performance, and diseases. And diseases like diarrhea and several other diseases. According to a report, 68% of deaths in children under 5 years of age in India is due to malnutrition. Keeping all these facts in mind, the Government of India and concerned state governments have been introducing many policies and programs targeting reduction of poverty and malnutrition. For example, Government of India started a program called Integrated Child Development Services, that is properly known as ICDS, in 1975. The ICDS has been instrumental in improving the health of mothers and children under age 6 by providing health and nutrition education, health services, supplementary food, and preschool education. Other programs also introduced, namely midday meal schemes, the National Rural Health Mission, and public distribution systems. In addition to these programs, several state governments also initiated many programs. For example, in Andhra Pradesh, government of Andhra Pradesh introduced many programs to ensure nutrition of tribal people through implementation of Poshna and Poshna Plus programs for pregnant women and children Under these schemes, healthy foods, lights, millets are providing through Anganwadi centers to tribal women and children, and children are getting milk from these centers. The teachers of these Anganwadi teachers also, uh, Anganwadi teachers who taught to pre-primary 1 and pre-primary 2 level schools must undergo proper training, which should reflect in the handling of the children. In addition to all these programs, government of Andhra Pradesh also initiated many programs in the name of Navratnas to provide to improve the conditions of living conditions of these poorer sections. However, situation is remains same. In this context, scholars who worked in this area noted that nobody goes hungry or suffers from any form of malnutrition. They suggested that to address this problem, India must do better. Accordingly, a structural shift in the dietary pattern and nutrition too, it requires a shift in production. This need is recognized by the theme of World Food Day 2021. The theme of this World Food Day 2021 says that our actions are our future. And it also stated that better production, better nutrition, a better environment, and a better life. These four betters are essential to tackle all these issues. While these are the remarks from scholars worked on these in this area. And so, with this brief, I thank all the participants who are patiently and actively participated in this national webinar. These few remarks. Now, I request our rector of Andhra University, Professor Chief Guest, today's Chief Guest, Professor Samta Madam Garu, to give her valuable message in this occasion. Thank you, Madam.
Thank you. Thank you. Honorable Vice Chancellor of Andhra University, Professor PVGD Prasad Reddy Garu, eminent resource persons, Dr. PV Sudhakar Garu, Principal, Andhra Medical College, Visakhapatnam, and Professor Sangamitra Sheel Acharya, Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University, New Delhi, and Dr. P. Subbarao Garu, Director, Center for Study of Social Exclusion and Inclusive Policy, Andhra University, students, scholars, academicians, and others. Good morning and a warm welcome to this national webinar. Today, our topic is poverty and malnutrition in India, issues and challenges. In India, 44% of children under the age of 5 are underweight. Majority of Indian population lives below the poverty line with resource crunch directly staring at their face. Though this poverty does not directly lead to malnutrition, it leaves a large chunk of population without adequate amounts of food. Poverty is a proximate determinant of malnutrition that mediates through inadequate dietary intake, lack of medical care, lack of access to sanitation and hygiene, and poor environment. Malnutrition is rampant among developing countries in which majority of population lacks access to 2 square meals a day, potable drinking water, basic health care, and sound sanitary conditions to lead a healthier life. Most African countries are home to children suffering from malnutrition. Then the key challenge before us is how to address the deep-rooted poverty. Central and various state governments in our country are implementing several public welfare measures to ensure the adequate supply of food grains to families below the poverty line through public distribution outlets. Supply of such essential commodities, some of which free of cost and others at subsidized prices to the needy, will go a long way in addressing the concerns of food security, thereby alleviating the severity of poverty in the country. So, reduction in poverty means better standards of living with children being groomed in a healthy and food secure environment. So, addressing concerns of food security will do away with malnutrition to a great extent. Roping into healthcare system more doctors by significantly increasing the people to doctors ratio in the country is crucial in dealing with public health issues. A lot of public health reforms and welfare initiatives taken across our country in recent years will hopefully address the twin problems of poverty and malnutrition. Let us hope for good tidings when children in our country will be healthy and free from malnutrition through welfare-oriented measures being implemented by government agencies. The initiatives of global organizations like UNICEF in addressing the problems of malnutrition globally by bringing awareness about public health issues are praiseworthy. Its efforts to rope in funds for the noble cause of ensuring sound health to children in their formative years are unparalleled. Let us hope for the world with a population that is above poverty line and free from malnutrition children. Thank you very much, Dr. Subbarao garu, for giving me this opportunity. Thank you very much.
Okay, madam, thank you for your valuable words on this occasion. With your cooperation in coming future, we would like to organize many such this type of programs through my center. Thank you, madam. Thank you so much.
Thank you.
Now I request my colleague, Dr. B. Sivaram Krishna, to introduce one of our guests, Dr. P.V. Sudhakar garu. Sir is Principal, Andhra Medical College, Visakhapatnam. Please.
Thank you, Dr. Subbarao, our director, for giving me this opportunity. I thank our director, Dr. P. Subbarao, for giving me this opportunity to introduce our two distinguished guests. The guest of the day, the first speaker, resource person, Dr. P.V. Sudhakar garu, is well known in the Visakhapatnam Medical Circle and also in Andhra Pradesh. It is a pleasant task to me entrusted to me by our director to introduce a great distinguished personality like Dr. Sudhakar. Dr. P.V. Sudhakar Garu is Principal, Andhra Medical College, Visakhapatnam. Professor Dr. P.V. Sudhakar Garu is Head of the Department of Plastic Surgery. He is Principal, he was Vice Principal, he was also Coordinator or Special Officer COVID Control for the North Coastal Districts of Visakhapatnam. He played a key role in combating and controlling COVID-19 during the most difficult times of first and second waves. His coordination of the medical team won the admiration of the state government and the people. Dr. P.V. Sudhakar Garu is a proud alumnus of Andhra Medical College. He graduated from Andhra Medical College in the year 1984, and he is also a specialist in plastic surgery. He has gone to pursue his Master of Surgery in and also Master of Chirurgy, Super Speciality, and Diplomate National Board from the prestigious institute, Postgraduate Institute of Medical Education and Research, Chandigarh. He is Fellow of Association of Indian Surgeons, Fellow of International College of Surgeons, and he is instrumental in conducting various conferences and workshops. He has visited several countries, and he is also the recipient of several awards like State Best Teacher Award from Government of Andhra Pradesh. He also won the fellowship of Scholar of American Society of Plastic Surgery, Republic Day Award for Outstanding Service, and many more recognition. He visited several countries, and his contribution to Andhra Medical College and KGH is well known in the city of Visakhapatnam. He has several memberships. Is member of Association of Phonosurgeons of India, Indian Medical Association, National Academy of Burns, and Indian Red Cross Society. He has been rendering services in plastic surgery, and areas that interest him include liposuction, autoplasty, abdominoplasty, blepharoplasty, cosmetic surgery, rhinoplasty, mentoplasty are some of the areas. Microvascular surgery are some of the areas which interest him. And it is a great pleasure to have a personality like Dr. P.V. Sudhakar Garu to address our participants on the health issues.
Yeah. Sir, am I audible and visible, sir?
Yes, sir. Yes, sir.
Is my screen visible to all?
Yes, yes.
Yeah. Right. Thank you very much, sir, for the wonderful introduction. And Professor P. Subbarao, the Director, Center for Study of Social Inclusion, Exclusion and Inclusive Policy, Andhra University, Visakhapatnam. Professor Samata, Director, Andhra University. Professor Sangamitra Acharya, the learned participants of today's national webinar. My special respects to Professor Prasad Reddy, the Honorable Vice Chancellor, Andhra University. And at the outset, I wish to thank Professor Subbarao Garu for having given me this wonderful opportunity to share some of my thoughts. And this particular subject being very close to the medical fraternity, I feel pride in delivering some opening remarks. I wish to tell that education is a power. Knowledge is power, as we all know. With education, we always improve. So, as you're all aware, poverty and malnutrition are inseparable. They are so entwined. Malnutrition leading to poverty because the individual's performance comes down. It has got a lot of economic bearing on the individual, leading to poverty. And poverty in turn leads to malnutrition because of lack of adequate resources for the individual to feed himself. So these two are so entwined, and solving one problem would automatically cause resolution of the other problem. So malnutrition and poverty are so closely related to each other that we should try to deal with both of them, and at the same time results can be obtained by dealing with one particular aspect so that it has got a direct bearing on the other aspect. Just bear with me for a minute. This is not showing up properly.
His voice is not audible, sir.
Yes, ma'am. Sometimes technical problem is there.
Okay.
They are rectifying it.
Okay.
Sorry for that small slight slag. Am I audible again, sir?
Yes, sir.
Again, the voice is not audible.
Am I audible, sir, now?
Yes, sir. Yes, sir.
Yes.
Hello?
Okay, sir. Okay. Proceed.
Am I audible, sir?
Yes, sir.
Is there any technical problem from our side?
No, it is not. No, madam, it is not from our side.
Okay.
Okay.
Am I audible now, sir?
Yes, sir.
Yeah, thank you. Sorry for that technical snag that we had here. We all know that according to the United Nations Sustainable Development Solutions Network in 2019, India has been ranked at 115 out of 162 countries. So, in terms of SDG ranking, that is Sustainable Development Goals Index, with a score of 61.1. So in Southeast and East Asia, India is in the 16th position out of the total 18 countries in this region. So only the neighboring countries like the Pakistan and Bangladesh stand behind India. So this shows us the grim situation of our country compared to what it is in the world. So coming to the BRICS nations, which consists of the Brazil, the Russia, India, China, and the South Africa. Amongst these 5 nations, India is at the bottom of these 5 countries. Sir, am I audible? There is some disturbance. Somebody wants to say something. Subbarao.
No, sir, nothing. Please continue.
Okay. So amongst the BRICS nation, India is at the bottom. I was telling you, India has scored the least for the SDG 9, so which basically deals with the industry, innovation, and infrastructure, which are very crucial for the economic development. So, yeah. Antecedents to this is the gender equality, which is SDG 5, and zero hunger, which is SDG 2. These two deal with the nourishment basically. The SDG 5 and SDG 2, they both deal with the hunger, and these are the other areas of very low performance as far as India is concerned. One good news has been that there are the trends of SDG 1, 8 and 13 suggest that India is on the track to attaining 2030 target for these three goals. So basically SDG 1 deals with the poverty eradication, SDG 8 deals with employment and economic growth, and SDG 13 covers the actions taken to combat the drastic effects of the climate change. So this is something which is appreciative and welcome sign. However, India faces the triple burden of undernutrition, overnutrition, and micronutrient deficiencies. This is something which we have to address, and this is what the reason for having this particular seminar today. So data from the National Family Health Survey 4 of 2015 and 16 basically shows that children under 5 years are stunted and wasted to the extent of 38% and 21% respectively. So at the same time, the rate of obesity under 5 years is at 2.4%, and the obesity amongst the adult women and men is also rising with 20.7% and 18.9% respectively. So men and women are increasingly suffer from this obesity. These figures are all quite alarming. The other nutritional deficiencies that we see apart from these three are anemia in women. According to the Food and Agricultural Organization of the United Nations, malnutrition keeps the people from reaching their full potential, affecting their health, which in turn is a barrier for social and economic development. So India also lags behind other nutritional indicators with high levels of anemia in women in the reproductive age group and low prevalence of exclusive breastfeeding in infants during the first 6 months. During the first 6 months, all the infants need to be breastfed exclusively without compromising. Almost 50.5% of women in the age group of 15 to 49 suffer from the iron deficiency anemia. Similarly, only 55% of the children are exclusively breastfed for the first 6 months. So the Global Nutrition Report says that India is one amongst the 88 countries that will miss the global nutrition target of 2025. So this is something which we all have to take cognizance of. And according to the Food and Agricultural Organization of UN, malnutrition keeps people from reaching their full potential, affecting their health. And this in turn is a barrier for social and economic development. So the cost of malnutrition on the global economy is enormous, and that is to the extent of 3.5 trillion US dollars per year. And if you take per capita, per individual, it is about 500 US dollars per individual per year. So this is quite alarming again. So the global hunger index in 2021, India falls in the category of serious hunger, ranking 101 amongst 116 countries. So the rank of India is 101, amongst 116 countries. That is quite alarming. So the steady progress in building human capital conditions for the children was put on a hold by this pandemic. As you know, that the decade-long progress that in improving the human capital, which includes health, survival, and reduction in stunting, led to the food insecurity and poverty. At the same time, the lack of adequate investment in health and education also led to the slower economic growth in our country. Stunting has lasting effects, as you all know. World Bank study has suggested that there is 1% shortening in the adult height due to the childhood malnutrition is always associated with about 1.4% loss of economic productivity. So that is the after effect of the childhood malnutrition. So one have to be very vigilant on this. There is a Pew Research Center which has used the World Bank data has estimated that the number of poor in India, which means that the income is less than $2 per day or less in purchasing power parity, which has more than doubled from 60 million to 134 million just in a year because of the pandemic induced recession. Because of the recession, the purchasing capacity of the people has significantly come down and it has become more than double. This means that India has returned to a situation where it is called the country of mass poverty. This has happened nearly after 45 years. So 45 years ago, ours was labeled as a country of mass poverty. And because of this pandemic that we have been seeing for the last more than 1.5 years, we have gone back to the stage of 45 years. So India has around 84 million population living in extreme poverty. So it is the most severe type of poverty, which is defined by the United Nations as a condition characterized by severe deprivation of the basic human needs, including food, safe drinking water, sanitation facilities, health, shelter, education, and information. So this basically makes up to 6.6% of the population of India as of May 2021. So at the same time, about 120 million additional people are living in poverty as a result of the pandemic that we are facing today, with the total expected to rise to about 150 million by the end of this year. And this is all dependent on the severity of economic contraction that's going to take place. Then, what are the challenges that we are facing? So, as you know, the low literacy rates, unemployment, gender inequality, corruption, and rapid urbanization, fast-growing urban slums, low productivity in agriculture, accessibility to healthcare, homelessness, lack of sound infrastructure, both physical as well as digital, and population explosion can be grouped as 10 most challenging problems that we are facing. Each have a relationship with others. So the problems of poverty and malnutrition forms a vicious cycle and are deeply rooted. So to break this chain and to uproot this problem, India has to tackle all these challenges that I have enumerated. So in order to discuss how to handle these challenges, we have identified the challenges, and to discuss these challenges, how to handle these challenges, we have the learned speakers like Dr. Samita, who will be dealing with subsequently. However, I draw your attention that a lot of initiatives were taken by the state of Andhra Pradesh in combating all these challenges over the past 2 years, so that I think progress can be seen in the next 2 years to come in most of these areas. And with that, I put my case to rest, and these are the references on which my presentation and my thoughts were based on. Thank you for your kind attention.
Thanks, sir. Thank you very much for your valuable information. Dr. Sir, you are not only touched with health aspects of this poverty and malnutrition, they also informed many surveys like SGT, Global Hunger Indexes, and so many economic issues and social issues in this occasion. Thanks, sir. Thank you so much for your cooperation. With your busy schedule, I know very well you participated in this webinar. Thank you, sir. Thank you so much. Now I request my colleague introduce another resource person, Professor Sangamitra.
We are fortunate to have eminent speakers for today's webinar. The other eminent speaker for this webinar is Dr. Sangamitra Sheel Acharya, Professor and Director, Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal Nehru University, New Delhi. Namaste, Madam. Professor Sangamitra Sheel has obtained her postgraduate degree from Jawaharlal Nehru University, specialized in population and settlement geography, MPhil in population geography, PhD from the same university, Jawaharlal Nehru University, specialized in the area of human urban social geography, social area analysis of the Delhi metropolitan area in the year 1995 from Jawaharlal Nehru University, Center for the Study of Regional Development. She has a brilliant academic career. Her areas of interest are environment and resource utilization, urbanization and urban health, gender and morbidity, youth and elderly, discrimination and exclusion in healthcare settings, which are the primary area of our center. Therefore, our director chose her as one of the resource person. And she had began her career as a lecturer in 1996 at International Institute of Population Sciences, Mumbai. Thereafter, joined as assistant professor in 1999 at Center of Social Medicine and Community Health, and continued in the same center where she became associate professor and also professor. He is visiting fellow of the University of Philippines Population Institute, University of the Philippines, Manila. She is also adjunct associate professor during 2008-2009 at Department of Sociology, College of Social Sciences and Humanity, Ball State University, Muncie, Indiana, United States. She has several fellowships, awards and rewards. She was also Director, Indian Institute of Dalit Studies, 2015-2010. She was a Fellow of Chinese Academy of Social Sciences, Beijing, China. Adjunct visiting faculty and ASF Fellow, University of Philippines. UNFPA Fellow, University of Botswana, Gaborone, Botswana. She has several publications to her credit. She has conducted several studies, field based studies. She has guided several scholars for her PhD, and she has contributed several papers, monographs, edited volumes, and other areas. And some of them are published in peer-reviewed journals also, in international, which are internationally acclaimed. Urban environment, some of them are urban environment, growing ecological concern, maternal and child health issues, gender issues, health and sexuality among youth in Philippines, etc. With this, and other primary publications, which are prime publications, are Caste and Patterns of Discrimination, Rural Public Health Care Service. He has published these papers in Delhi, Oxford University Press publication, and also Financing Health, Some Issues and Concerns. Others are some social discrimination and access to healthcare. The study of Dalit children in Western India. These are some of the publications. He has also addressed several seminars as keynote speaker, invited guests, and several talks. And it is very difficult, it has become very difficult to condense in a 5-minute capsule of the biography of Madam Sangamitra. Thank you, sir, Professor Subaragar, for giving me this opportunity.
Okay, madam. Thank you. Welcome.
Thank you so much, Professor Subbarao. It's my privilege to be here today sharing some of my ideas with the group that you have organized. At the onset, I wish to thank you as Director of the Center for the Study of Social Exclusion and Inclusive Policies. I wish to place on record my gratitude to Vice Chancellor, Professor Prasad Reddy, Madam Rector, Professor K. Samanta, and all your colleagues who have put together this event. I am also overwhelmed to have Dr. Sudhakar alongside me as a panelist. And after having listened to his erudite lecture, I am actually wondering what is it that is left for me to speak. Nevertheless, being a social scientist, I would want to place in front of those of us who are here for this event as another dimension of this intersection that we are trying to understand between poverty and malnutrition. In fact, if I may say so, Dr. Sudhakar has made my job slightly easier by portraying for us the larger backdrop within which we need to understand how malnutrition is associated with the larger context of poverty. It may sound very, very obvious, but the trajectories which actually make this intersection function become very important to deal with. And with this, I would want to probably bring to us the section of population who get affected both with poverty and malnutrition in a particular specific way. Because of historical deprivation. And I thought I consciously chose this aspect because I thought since the event is being organized by the center, which is mandated to understand social exclusion and the policies which are relevant for inclusive measures, I thought this was a good idea and a good platform to talk about the marginalized groups and how to they become vulnerable or how their vulnerabilities are enhanced because of poverty and the consequent malnutrition and also the subsequent poverty, which is again, it becomes like a vicious cycle, which the very first slide of Dr. Sudhakar kind of showed us. I'll try and share my slides with you and take us through this realm of the ideas that I'm probably trying to talk in terms of. As we all know, and I've just said that I would try and see how have the nutritional differentials across population groups have behaved, particularly because of historical deprivations, and can we talk in terms of what are the causes and consequences, and therefore can we think about whose responsibility is this, and how do we respond to this situation in which we are finding ourselves in terms of the malnutrition conditions. To begin with, I would wish to quote one of the recent papers which was published in PLOS One journal, a fairly acclaimed journal which talks about health and nutritional issues. This paper highlighted that the average height of Indians has been decreasing in last couple of decades, and this was based on the data which we are all very familiar with, National Family Health Survey data, highly acclaimed data globally. It suggests that over this period of time, there has been a declining trend in the height of Indians whereas when we're looking at populations over the world, across the globe, it's been showing a trend which is increasing. So this perhaps became a cause of concern among people who are interested in health, in nutritional conditions of populations, which is very important, because we all know that height is a very, very standard measure of physical well-being and the biological parameters which we find the populations embedded in. And we all are very familiar that when we actually talk about nutrition, besides genetic potential, which also has some connect, if we go in the backdrops, to the larger socioeconomic conditions in which populations are located, what has been the illness history, what is the access to quality health services, and therefore the food security realms also, which in totality impact on what exactly will be the physique of the human populations, individuals as such, and individuals put together as groups for that matter. So given this kind of a scenario, it really was a cause of concern. Why is it that the height of the Indians is seemingly increasing? And this perhaps also needed to be seen in the light of what Dr. Pangadia had a couple of years ago made his observation in terms of stunting, and the response which he got to the comment that he'd made vis-a-vis the stunting, because this certainly had a lot to do in the larger paraphernalia which we are seeing in terms of the socioeconomic conditions, which are directly telling us about the realms of poverty, which perhaps becomes very, very important. Now, much of the literature that we've kind of come across in terms of the stunting, the realms of height, etc., a lot of literature is talking about children. Because again, perhaps our obsession has been with the health of mother and child, largely to address the context of population rise, population increase, which to my mind is something which has to be seen in the light of resource redistribution as much as in terms of the staff numbers. We'll come there a little while later. So the context is at the moment that over and above children, I think we need to look at what is happening to the adult heights, adult nutritional status, which is impacting on the heights that we've just about talked in terms of. Therefore, let's take a look at what are the backdrops in which vulnerable populations are located. And I'm trying to make comparisons between the standard social groups which most administrative data tells us about, gives us information on. So if we categorize our population in terms of scheduled caste population, scheduled tribe population, other backward classes, and those who fall in none of these categories, the others, which is technically categorized as others, we see very clearly that when we think in terms of the capacities, social capacities, literacy is about 66% among the scheduled caste population, as against the average national literacy levels of more than 70%. What is interesting to perhaps note is that the gender differentials, even among the SCs, is as very similar to the non-SC populations. More than 3/4 of the SC men are literate, as compared to a little over half of SC women who are literate. What is perhaps applaudable that the gap between the men and the women seemingly is reducing as compared to in terms of the literacy differentials. this also then brings us to the next point, that what is happening in terms of the gap which is reducing, which then certainly tells us about the positive side, that there are more women who seemingly are educating themselves, even if there are more people who are kind of remaining at the primary levels of education, just about 16% as compared to only less than 3% who are graduating. So what's therefore important is that in these backdrops of some progress but persistent gaps, we do perhaps want to also look at how do these sorry, I think somebody needs to put the microphone off. Sir Subbarav, I can hear a disturbance. If we can put the microphone off. Thank you. Hello. I'm audible, Professor Subbarav?
Yeah.
Okay.
Proceed, ma'am.
Sorry, there was some disturbance, so I was wondering from my side.
Okay.
So alongside perhaps the literacy, the other context which also becomes important to think along the lines of the marginalities which evolve is the work-related aspect. And we very well know, we're familiar with across literature, across various kinds of data sets, that when we look at women workers particularly, the share of non-SC/ST women workers are largely contributing towards work as cultivators, whereas when we look at the scheduled caste women workers, they're largely as working as agricultural laborers, which is we're familiar with, considered as an unorganized sector, and therefore their position as agricultural labor, which isn't organized, kind of puts them more vulnerable, aggravates the vulnerability in terms of all kinds of social security, which would be available to those who are from other social backdrops. Similarly, in the urban spaces also, we see that a large share of Dalit women, if I may use that terminology, are employed in again as other workers, which is largely in engaging in factories, plantations, small trades, which gives them very little access to any kind of capital for that matter. And this is also perhaps because of the comparatively lower levels of literacy, where in the situation which is, relating themselves in terms of their propensities to be able to earn better gets affected. Lower levels of literacies also influence their ability, their capacity building in certain ways, their skill buildings in certain ways, and therefore the work that they can access, which in all possibilities affects their levels of poverty, as well as the nutritional security that they can get for themselves as well as their families. Therefore, very neatly we can see these as pointers that it affects their own health, and a lot of weightage is given to women in terms of their motherhood. Therefore, a very direct impact is on the safe motherhood, the children that they give birth to, how long do they survive, and all of it is connected in terms of the existing nutritional status and the nutritional status, which perhaps could be a result of, let's say, frequent pregnancies, for example, inadequate nutrition during pregnancies. So a lot of women, if you really look at the institutional care which could be provided to women who are giving birth, is much lower among the SC women as compared to women who are from non-SC categories, or let's say non-SC and non-tribal. I'm not bringing tribal here at the moment, but they're equally vulnerable. So a lot of women who are from vulnerable communities are seen to be affected by chronic energy deficiencies. So a lot of burden of nutritional deficiency is being contributed by the vulnerable populations because of the historical deprivation that they have been experiencing. Just a snapshot for us to get a sense of how socio-demographic characteristics or indicators influence a very, very stark idea of, if you look at what mother's education does. And again, let's remember education has a lot to do with both social and economic propensities. So when the mother's status of education in terms of education is no schooling, we see that nearly 37% is the early childhood mortality. As we see the increase in levels of education, more than 12 years or so, the levels reduce to less than 6%. Similarly, if we look at the economic propensities, lowest wealth quintile has highest early childhood mortalities. More than half the mortalities rested in this wealth quintile, whereas the highest quintile has less than 1/5 of the early childhood mortality which is happening. So just to get us a sense of, therefore, what becomes important for us is to look at what are the backdrops in which we can say these elements are becoming functional. So if you look at the underweight women, adults, both men and women for that matter, and like I said, let's take a look at what's happening to men over and above the children. We can see a fairly stark differential across social categories, both scheduled caste and scheduled tribes, vis-a-vis those who are privileged groups, privileged communities, if I may use that term. While there is almost 1/4 of women and little less than a quarter of more than 1/5 of men who are underweight, as compared to about 18% who are from the privileged groups. And therefore, I think what becomes important to take note of that this is something, why is it that this gap exists? And that's where perhaps it becomes important to take cognizance of the fact that there are certain groups which have remained deprived of the access to resources as compared to those who have been in the privileged social groups. And therefore, and I'm quoting this, I'm sure it's available for all of us to take a look at, Shazia Nigar's work, which very categorically has examined how caste-based discrimination and economic deprivation over the period of time has induced some kind of the problems which are faced by women in accessing any kind of, and it's more than 70% of vulnerable women from Dalit communities who cannot access because of the discrimination based on these realms. Therefore, yet another point that I would want to bring in over here, particularly in the light of what is said, often being said again, all over again now, the pressures which population size is creating. I'm a little wary of kind of saying that or agreeing to that, because in last 2 decades now, we have been seeing declining fertility trends. There's a decline in natural increase also. What therefore becomes important is to take a note of how the resources are being distributed, how the resources are being allocated to different population groups, rather than reinventing what was perhaps in the 60s and the 70s more relevant in terms of the numbers and the size and the rate of growth. In fact, the rate of increase has been on the decreasing trend. So that is something we have to cautiously understand when somebody tells us that it's the numbers which are increasing per se. What I wanted to share therefore for us is like, despite the fact that there has been historical deprivations. When we look at the sex ratio, ratio between male population and the female population, very interestingly, among the SC population, we see that there is an increase of number of women per 1,000 men from 2001 to 2011. This is census-based data. And the similar trends have been visible in urban and rural populations among Dalits also. What is important is that sex ratio, we all know, is an important indicator for gender development. So we see that as against the privileged groups, the Dalit groups seemingly have better sex ratio, although there are references which are suggesting that child sex ratio, however, seemingly has been declining, although even this decline is slightly lower than the decline in the privileged communities. So the point, therefore, I was trying to make here, or bring for us to take note of, is that despite deprivations, there are certain elements which perhaps are working better in terms of the realms of gender parity among the underprivileged groups as compared to the privileged groups. Therefore, to reiterate that there have been certain structural realms because of which discrimination has been experienced by certain groups, and I'm bringing in the realm of women, particularly because Dalit women per se is lowest in the social hierarchy in terms of access to resources. And therefore, if I may borrow from what the Lancet Medical Journal report of 2015, which connects the conditions of health and the caste scenario in the country, there were 3 pointers which the report kind of suggests. One, of course, there is genetic impact, genetic factors which impact health. What is the early life course environment, and what are the opportunities which may be utilized for any kind of social mobility, particularly upward mobility. And that's where perhaps the access to resources becomes very, very important. And since all of these are impacting on health for sure, we wouldn't deny, is dependent majorly on the nutritional security. And that's perhaps why the state has taken on itself as a responsibility to ensure food security. And we have legal safeguards, constitutional safeguards for that. Therefore, if I have to reiterate this argument that deprivations have made a certain impact on the lives of people who had problems in accessing resources, what is fairly evident is that when we as individuals, we as groups have to access certain kind of services, what becomes difficult is that many a times the location of the vulnerable populations is such that even the closest facility could be at a distance which is not conducive in terms of cost for me as a vulnerable woman to be able to access it. Money or financial support certainly is an important aspect for it, and it is fairly evident from the national data set, which is NFHS, which tells us almost more than 70% of women who come from Dalit communities, the SC women, have reported that they've experienced problems in accessing any kind of care. What is interesting perhaps is to note is that despite the continuous problem that they've been facing in terms of accessing any kind of services from the health facilities, distance being one, the other being provider not being available, interestingly, if we note that over the period of time, this is late 2000 8-9, and this is 2015-16, NFHS 4 is 2015-16, we see that the difference between the scheduled caste women who couldn't access the services versus those who were from the privileged groups seemingly was about 18 percentage difference was about 18 percentage points, which kind of reduces to the time 2015-16. So which means that certain programmatic initiatives, certain policy formulations have made certain difference in terms of making access possible. Similarly here also, where non-availability of provider has been fairly important, and we see the gap something to the tune of about 6 percentage points, reducing to about 4 percentage points over 1998-99 to 2015-16. What is important is that the gap still exists, because if the services are available for everybody at par, and this is the public sector that I'm referring to, then the gap shouldn't actually be existing. The environment should be such that anybody from any social group should be as explicitly be able to access the resources. And that's why perhaps for us as scholars, for us as researchers, for us as conscious citizens, it's important to take a note of these persisting gaps and perhaps make a sense out of these. And this is also becomes important, and again I'm drawing from the same data source, which is also suggesting that because of these situations which leave the gap in terms of access to resources of various kinds, we see even the life expectancy, this is again pertaining to children, life expectancy as age 1, when the children are about a year old, what exactly is the life expectancy? Here again, we see that there is a gap of about 2 to 3 years, which is existing across the privileged and the underprivileged groups. The pointer for us is that we take any indicator which is resting or which is telling us a story about what could be the connection between the poverty levels and the nutritional intakes, nutritional status. A persistent gap is visible across the privileged and the underprivileged groups. I mean, any data set that you wish to kind of point out. The saving grace is that there is kind of reduction in the gap, which means that there is something happening in terms of the outcome of the programmatic initiatives, which is where perhaps it becomes important. While there is an overall improvement, what is important to see that the outcomes of these implementations have been better utilized by the privileged as compared to the underprivileged. And that's where perhaps the initiatives have to be there. Perhaps we need to have certain group-specific policies, therefore, to be able to bring this gap, bridge this gap in all possible forms. Another pointer which I would want to bring in for us, again, in terms of the differentials between the nutritional status of women across social group. NFHS 4, the latest data set which tells us about health and family status of the population, it very categorically states that 1/4 of Dalit women who are in the reproductive ages are undernourished as per the body mass index. That's one of the measures that we use, as compared to about 1 in every 6 women who are from the privileged communities. Similarly, we can take into account, we've just had a look at some of the indicators, the differentials that we see between women from underprivileged groups versus women from the privileged groups. Lifespan itself, this was something which was very, very stark particularly when the report was released. There's almost a gap of 14.5 years when it comes to the average death at average age at death. Dalit women die less than 40 years of age, whereas the non-Dalit, the privileged women, have an average death age at death 54 years, and the gap is such as this. So, like I said again earlier, also, if the potentials to access nutritional programmatic initiatives, all that which is being done for women in terms of their maternal and child health, if all of this is accessible to everybody programmatically from the state response perspective, why is it that we see these differences persisting? And therefore, perhaps we need to understand why these differentials persist. What are the causal factors which kind of do not allow this gap to be bridged in? Something very interesting, Dr. Sudhakar had been talking about the Sustainable Development Goals, which actually rest on the Millennium Development Goals, which we seemingly had to attain by 2015. And since we did not, we see the other set of Sustainable Development Goals. Very categorically, it's been said fairly well and fairly well publicized also that it's very, very the first 1,000 days of a child's life of very important because they kind of lay the backdrop of the rest of the life. But because of high prevalence of low birth weight and undernourishment in developing countries, we fail to kind of come up with the ability to meet the goals which are often set up. Particularly because children who are exclusively breastfeeding or who are breastfeeding are largely dependent upon the nutrition which the mother will provide. And if the mother's own nutritional status is poor, it gets directly, you can see the impact directly on the children. Therefore, to be able to associate how do we influence, what are the probabilities which can which would support in making some kind of difference. When it comes to decision making to access any kind of health facility, health care, it's important that we have certain decision-making power and certain financial support. Now, interestingly, when we look at the decision-making difference across men and women and across social groups, the comparative difference across social group is comparatively lesser than the outcome variables that we were just taking a look at. Nevertheless, the gap is there, and we can also see the gender differential in terms of the decision making for the health of the women. Now, access to money and being able to make this choice of going for health care is to be seen in Connect. Even when more than nearly 3/4 of the Dalit women, for example, can take the decision to be able to go and take some kind of healthcare services, it's just about 40% of them who have any kind of access to monetary support or financial support. And therefore, that decision making gets obstructed by their capacity to be able to use it. And then that's where perhaps we need to relocate ourselves and take a look at what we were seeing a little while ago in terms of their propensities, their work regimes in unorganized groups at low-paid jobs, etc. So that's another aspect that we might want to take on board. And all of this, for sure, we need to see in the global scenario. Dr. Sudhakar had just talked about how other poverty dimensions globally have influence. Now, perhaps another important aspect, since we are talking about nutrition, we haven't really fared very well when it comes to minimizing the hunger levels in the country. All the more, perhaps it's appalling because we've been producing food fairly upwardly. I mean, there's been any economist will probably contend to this, that the food production almost consistently has been rising in the country. But when we look at the global hunger index, I missed out on the 2020 figures, but they don't seem to be faring any better. Out of 117 countries in 2019, we ranked at 102, improved a little from the earlier years. Which is actually corroborating what the NFHS data has been telling us in terms of the Dalits and the Adivasis, in terms of the deprivation, in terms of access to health facilities, and also the nutritional security that state particularly is providing. So the context of physical location vis-a-vis facilities, vis-a-vis resources which could be accessed from, most of the vulnerable groups have to travel longer to reach a health facility, for example. Many a times they're not in a position to be able to meet the healthcare providers. If the healthcare providers are available, the time which is spent with the healthcare providers is also differential, again by way of the propensities, both social and economic, in terms of the time which is disseminated. And this is part of a study which I myself was involved in doing, trying to understand what was happening to women and children in Western India when it came to accessing services, both at the grassroots level and at the community level. Like I was saying, that although a lot of research has concentrated on status of children, and I just wanted to kind of bring at par with what we've been talking about the adult population, we do note that the gap which is there in terms of almost to the tune of 1:2 between the scheduled caste and the privileged group populations when it comes to the nutritional status among the children. Anemia, also we see a similar kind of difference which is persisting. What is perhaps important is that something which is affecting the access to, for example, ICDS services. ICDS services are particularly meant to ensure nutritional intake of the children. So if the gap continues to persist across social groups, both in terms of what the intake could be and as an outcome of that intake, I think I'm just trying to perhaps reiterate once
Madam.
Hello.
Madam, please listen to me.
Hello. Hello. Okay, so the idea of
Some problem is there with you.
Hello.
Madam, no, madam.
Yes, please. Hello. Hello.
Okay. Now it is okay, madam.
Okay. It's visible and audible?
Yeah.
Okay. So the point I'm therefore making is that whether we talk of adult population or we talk of children and infants, the persistent gap across social groups, persistent gap across privileged groups versus underprivileged groups continues to remain there. And that's where perhaps we have to think in terms of the access to the resources which need to be equitable rather than equal. And I consciously try to bring in this distinction between equal access versus equitable access. All of us may not require the same amount of any supplement for that matter, but each one of will have a differential need, which is where we need to think in terms of equitable rather than equal. And this is what I was trying to bring in terms of what the programmatic initiatives could have been doing it for the infant, for the children below 5 years of age who are kind of receiving any service through ICDS, almost 10 percentage gap between the privileged and the underprivileged groups that we are seeing over here. Similarly, for children who are below 5 years of age. So the point I'm trying to reiterate is that state's response is there. There are trends which are showing us positive results, yet the gap continues. And that's where perhaps the need to strike some kind of group-specific policy so that this gap, all this while we've been having certain kind of initiatives which are addressing the needs at par across social groups, but we have not really managed to bridge the gap, and therefore I would contend that group-specific policies become very, very important. And just to end the story with what COVID has done to us, over and above what we've just got to learn from Sudhakar, that the poverty itself has kind of doubled to some extent in last 2 odd years of pandemic. Even the vulnerability of women, children of different ages seemingly have increased in terms of their loss of job, in terms of their illnesses which were not pertaining to the non-COVID illnesses, the child birthing conditions, the conditions of postnatal care have influenced and impacted women in very, very different way. There are reports, there are papers which are telling us the stories that women did not manage to get the kind of services which they would have otherwise gotten. So the kind of pressure which was built not only on the healthcare service because of the pandemic, it also kind of triggered in all other realms of the lives, which women particularly could have experienced alongside other populations, elderly population for that matter, the disabled population, people with alternative sexuality. We very often do not talk about them, we do not think about them. So all of this becomes extremely, extremely important to think in terms of when we are connecting this link with between poverty and nutritional stability, nutritional status, because this intersection, to my mind, is a very strong intersection which connects to almost all sectors of development. Be it health, be it education, be it industry. And that's perhaps why when we transcended from the Millennium Development Goals to the Sustainable Development Goals, very elaborately, there were realms which were put together in such a way that there would be some kind of connect with health, the third SDG, if I may put it so, with all other sustainable development goals. Thank you very much. I'll close and I'll be glad to take on questions, if any. Thank you so much, Professor Rao.
Thank you, madam. Thank you so much. Audience, anyone would like to ask any questions? Please, no problem. Interact with madam. Anyone? Okay. Thank you so much, madam. You gave very, very important insights on these issues. Particularly, I noticed that the average height of Indians has been decreasing from time to time. That is a very interesting observation from your side. Not only this, madam, you also discussed about socio-demographic indicators, uh, work vulnerables particularly,
Yes.
and you also clearly explained about the importance of mother's education to tackle all these problems. Then you also how social identity-based discrimination is going on in our society. Madam, you also discussed about social mobility and poor economic conditions hindered healthcare services in our society, madam. Thank you. By referring all those issues, you compared all these issues with reference to privileged and unprivileged classes, madam. Thank you, madam. Thank you so much your participation, your presentation. You are very busy, I think. Professor Channarao told me earlier. You are so very busy. However, he spent this much of time uh, to deliver this message, madam. Thank you so much. Thank you. Then I request my colleague Dr. B. Shivaram Krishna to brief the proceedings of this webinar within 5 minutes. Shivaram Krishna.
Participants and the resource persons, esteemed resource persons, chief guest of the program. Before I just try to brief the program by we are grateful to our Honorable Vice Chancellor, our Director. This program was envisioned by our Director on poverty and malnutrition, particularly in the COVID times. And only 8 days ago, we wanted to organize this webinar. Soon he contacted the resource persons and identified the 2 resource persons who are most distinguished in their respective fields. Dr. Subbaragaru has highlighted the issues of poverty and how the poor and marginalized represent the majority population in India, and also who are also responsible for malnutrition. And he identified that malnutrition is more among the poorer sections and the weaker sections of the society. And the role played by the government with the institution of ICDS services in 1975. Professor Samta Garu has highlighted the aspects of underweight, and she pointed out that poverty is a proximate determinant. Lack of medical care, hygiene, and poor sanitation are responsible for malnutrition among the poorer sections of Indian society. And she compared Indian society to African society, which is also malnourished. Majority of the people in Africa, East Africa, North Africa, and all those places are malnourished. And malnutrition is rampant in developing countries. And according to her, some systematic approach is required to address the issues of malnutrition and poverty and malnutrition. According to her, if poverty is addressed, malnutrition can easily be addressed, because malnutrition is a consequence of poverty. Scholars and economists like Payne and also others have indicated that food security is essential for addressing the issue of malnutrition. And welfare-oriented measures need to be taken on a priority basis. Dr. Sudhakar Garu has highlighted the aspects of nutritional deficiency, anemia in women, and he pointed out that children under 5 years are wasted and stunted. He expressed with concern the rate of obesity which is rising among adult women and men. He also referred to Global Hunger Index and stated that India is ranks at 101 among 116 countries. in terms of hunger is alarming. He expressed the hope that human capital need to be enhanced. Human capital in the sense health, education needs to be given a priority. The income, he expressed that the income of an average Indian is less than $2 a day, which is alarming. A conditional deprivation by food scarcity is to be addressed, observed Dr. Sudhakar. These several challenges are put forth, and he identified some of the challenges as low literacy rate, unemployment, rapid urbanization, urban slums, homelessness. All this will go a long way in addressing poverty and consequently malnutrition. Population explosion is one aspect she observed to be taken as a priority. Population is not to be considered as a curse. Population need to be turned into be a boom. India needs to take advantage of this demographic dividend. And Professor Sangamitra Shil Acharya ji has identified, touched upon several aspects. She touched she expressed with concern the literacy rate among female Dalits and observed that the female literacy among Dalits is narrowing. She has done extensive work with on underprivileged sections, and she has centered her talk upon the vulnerabilities of the marginal sections, especially SC/ST women, and their health issues. She has identified the urban-rural divide with respect to health, education, and also the aspects of underweight, the health determinants like weight, sex ratio, demographic trends among the privileged sections and underprivileged sections, the oppressed sections, the social identity-based discrimination which affects health has been given necessary focus. Her presentation also touched upon the aspects of differentials in life expectancy at the age of less than 1 year. She pointed out that children below 3 years need to be given necessary nutritional status. Their nutritional status must be improved. Mothers of such children must also be given nutritional food so that the child and the lactating mothers would have better health status. She has given that no doubt there are several policies that have been put in place by the government to improve the health outcomes, which has resulted in reduction of IMR, infant mortality rate. She referred to various reports, NFHS studies, reports 3, 4, and 5, and made a comparative study of the National Family Health Surveys and other data. She has done extensive work. The presentation has pointed out the various studies. He has referred various studies and gave a snapshot on the demographic trends, global hunger aspects, and also observed the rate of global hunger. As suppose India was at 102, was ranked at 102 out of 117 countries in 2019. Its position was 103 out of 132. India was at 100. India occupied 100th place out of 119, 2017. So therefore, these studies have given a clear picture about the issues of malnutrition and poverty, and how the physical health status would have an impact upon the economy, the individual, and the economy. How the underprivileged sections, especially scheduled castes and Adivasis, would take the benefits of the governmental policies by giving their health determinants. She has given a picture. She has given a wonderful presentation on the aspects of health determination of SC/ST compared to other social groups. And she has also given the access to HCDS services by underfed children and also parents and mothers, lactating mothers and others. And she also explained the aspects of vulnerabilities of poor people, especially affected by the pandemic in India. So with these few words, I feel that I have done something to give a picture of your presentation, madam, of presentation of Sangamitra Sheila Acharya and Dr. Sudhakar Garu. I thank our director for giving me this opportunity for summing up the outcome of your presentation. Thank you.
Thank you, Dr. Sivaram Krishna. Now I request my colleague, another colleague, Dr. Jan Babawali, to propose a formal vote of thanks.
Good afternoon, one and all. I am Dr. Babawali, Research Assistant, Center for Study of Social Exclusion and Inclusive Policy, Andhra University. On behalf of the Center for Study of Social Exclusion and Inclusive Policy, Andhra University, on the occasion of today's valedictory session of the one-day webinar, Poverty and Malnutrition in India, Issues and Challenges, I am very happy to present formal vote of thanks to the esteemed dignitaries, participants, participated in this webinar in different categories. It is my privilege to thank today's chief guest, Professor K. Samata Garu, Rector, Andhra University, for his wonderful and inspiring speech on today's topic, Poverty and Malnutrition in India, Issues and Challenges. My thanks are also due to today's one of the resource person, Dr. P.V. Sudhakar Garu, Principal, Andhra Medical College, Visakhapatnam, who gave elaborate information on the issues and challenges poverty and malnutrition in India. I am also thanking to another resource person, Professor Sangamitra Sheila Acharya, Center for Social Medicine and Community Health, School of Social Sciences, Jawaharlal University, New Delhi, who gave an extempore speech on malnutrition and its impact on health. And also, madam, we are very much benefited with your statistical analysis on the different issues like this malnutrition issues, madam. Thank you, madam. Thank you very much, madam. My thanks are also due to the all participants who registered and participated in this webinar. My sincere thanks are also due to the Andhra University administration for their constant support to organize webinars and also undertake many research projects, especially on the excluded groups. I also thanks our director P. Subbarao Garu, conducting numerous relevant programs and running the center effectively. Thank you, Ananda.
Okay, madam, thank you. With this, the seminar is closed. Thank you, madam.
Thank you very much.
Thank you.